everyone. My name is Stacy Kenyon, and I'm a clinical chemist at Phoenix Children's. I currently oversee both clinical chemistry and point-of-care testing for the system. Thank you for joining me today for this discussion regarding blood gas specimen integrity. During today's talk, I will be providing some background refresher information regarding blood gases and blood gas testing. I will also be discussing an ongoing initiative at Phoenix Children's that is being implemented to help improve blood gas specimen integrity. You'll notice in the title that I call it a journey, and that's because it really has been an ongoing and iterative process over the last year. During today's presentation, we'll cover the following learning objectives. 1. Identify pre-analytical variables that impact the accuracy of blood gas specimen results. 2. Discuss strategies to reduce ambient air exposure during the blood gas specimen collection process. And 3. Describe collaborative interventions by laboratory and nursing aimed at improving blood gas result integrity. During today's presentation, I will be providing some definitions of different blood gas testing parameters and how they are measured. This is just to ensure that we are all aligned as we work through the presentation. However, I will not be discussing physiological acid-base balance or how to interpret blood gas results. So blood gas testing is used in the evaluation of a patient's respiratory, circulatory, and metabolic status. While it can be used to monitor patients in routine care situations, it is more often used in acute and critical situations that require immediate clinical decision-making and interventions. So it's extremely important that we have reliable results. Traditionally, the term blood gas refers to those parameters listed here: pH, PO2, PCO2, and SO2, or oxygen saturation. However, many blood gas analyzers also include oximetry measurements for the measurement of total hemoglobin as well as hemoglobin derivatives. Additionally, many blood gas analyzers also allow for the measurement of chemistry analytes such as electrolytes, lactate, and creatinine. Blood gas testing can be performed on specimens from multiple sources, including arterial, capillary, and venous. For blood gas testing, arterial is the gold standard specimen source as it accurately represents the oxygen levels available in the body's tissues as well as reflects the systemic acid-base balance. Additionally, most of the research and literature involving blood gases was established using arterial samples. However, due to the invasive nature of arterial draws, clinical teams may sometimes use venous specimens. Of course, the interpretation of these results is going to be significantly different from the interpretation of arterial specimens. As mentioned previously, blood gas testing can be used in both routine and critical situations. With this in mind, it should be of no surprise that blood gas testing can be performed in central laboratories as well as at the point of care. And some of these point of care scenarios would include emergency departments as well as mobile transport units. Before continuing, I do want to take a couple minutes just to review some basic blood gas terminology. Again, this is just to assure that we're all aligned as we work through the presentation. And again, I will not be discussing the physiologic acid-base balance or the interpretation of blood gas results. But I do want to take a moment just to go through these terms as I will be using them later in the discussion. pH is the index of acidity or alkalinity in the blood, while PO2 is the partial pressure of oxygen in the blood, and PCO2 is the partial pressure of carbon dioxide in the blood. PCO2 is also the respiratory component of acid-base balance. All three of these parameters are measured via electrodes. Bicarbonate is the metabolic component of acid-base balance and is actually calculated from the Henderson-Hasselbalch equation using the measured pH and PCO2 of the sample, while SO2 or oxygen saturation is traditionally calculated from the oxygen dissociation curve when using blood gas analyzers. As we'll discuss on the next slide, oxygen saturation can also be calculated via oximetry and co-oximetry. And in these cases, they're usually referred to as functional saturation and fractional saturation. The relevant co-oximetry terms, or some of the relevant co-oximetry terms, are shown on this slide. Total hemoglobin is one, which is pretty straightforward. The second one would be the percentage of oxyhemoglobin, which is just the fraction of total hemoglobin that is present as oxyhemoglobin. The percentage of carboxyhemoglobin is therefore the fraction of total hemoglobin that is present as carboxyhemoglobin, and then similarly with methemoglobin. All four of these parameters are measured using absorption spectroscopy. SO2, percentage or oxygen saturation, which I may just be referring to as SO2 for the rest of the presentation. In this case, it is calculated using co-oximetry measurements and is the ratio of oxyhemoglobin concentration and the concentration of functional hemoglobin. While SO2 is still a calculation when using co-oximetry, it is calculated directly from parameters that are measured using absorption spectroscopy. So while we discussed that blood gas specimens are often ordered in critical care and acute situations that require immediate decision making, it is important to understand that blood gas specimens are subject to pre-analytical variables, just like all specimens collected for laboratory testing. Due to the manual nature of the pre-analytical process, it is just going to be prone to errors. And of course, specimen collection is part of the pre-analytical process as well as specimen transport. While blood gas specimens are prone to many of the same pre-analytical variables as all samples collected for lab testing, such as patient identification errors and transport temperature errors, blood gas samples are susceptible to some additional errors. Some examples of pre-analytical variables that impact blood gas testing uniquely are shown in this table. This table also includes the parameters that are impacted, as well as the direction of the impact. The first source of error would be inadequate mixing of the specimen, which leads to clots, and we can either have microclots or clots that are large enough to see. Ultimately, clots lead to non-uniform distribution of cells and anticoagulant, which can lead to inconsistent or erroneous readings and really impact all parameters. If clots are large and introduced into the analyzer, they can also clog the fluidics and cause analyzer malfunction. To prevent this, just ensure that samples are mixed thoroughly after collection and immediately before measuring if there's any type of delay. Delaying analysis of blood gas specimens, particularly if the specimens are kept at room temperature, can also lead to erroneous results. So it can lead to increased pH, decreased PO2, and increased PCO2. These impacts happen as the result of cellular metabolism, which leads to increased CO2 and lactic acid in the specimen, which results in the decrease in pH. The cellular metabolism also consumes oxygen, reducing the PO2. Room temperature specimens should be measured within 30 minutes of collection according to the CLSI guidelines. The next source of error is exposing the sample to air. This can happen either during the collection process itself or by the introduction of air bubbles. So exposure to air will lead to an increase in PO2, a decrease in PCO2, and an increase in pH. This is because the PCO2 of room air is 150 millimeters of mercury, which is less than the PO2 in a blood specimen, assuming that there's no oxygen supplementation. So when the specimen is exposed to air, the PO2 of the sample will increase. The PCO2 of the specimen will decrease as the CO2 from the sample moves into the air during the air exchange process, which is also then going to lead to an increase in pH. The impact of air bubbles is exacerbated when there's delayed analysis or when the samples are transported via pneumatic tube. So ultimately, specimens should be collected without air exposure. The next source of error would be the incorrect specimen sources collected. So this can also lead to unexpected results. For example, if an arterial blood gas is ordered but a venous specimen was collected, pH and PO2 will be decreased while PCO2 will be increased from the normal. It's important to order and collect specimens from the correct source to prevent these types of errors and interpretation issues. Blood gas results are also temperature dependent. So if a patient is hypo or hyperthermic, results may be inaccurate. Most blood gas analyzers allow for the entry of patient temperature so that we can avoid this pre-analytical variable. While there are many pre-analytical variables that are associated with blood gas specimen collections, we will spend the remainder of this talk focusing on air contamination. And for the purposes of this presentation, air contamination can refer to specimens that have prolonged exposure to ambient air or specimens that have air bubbles introduced into them. The impact of air contamination can lead to negative clinical impacts, as with any inaccurate lab results. So blood gas specimens ultimately with air contamination can lead to incorrect interpretation of the results, incorrect treatment, and as well as inappropriate interventions or inappropriate lack of interventions. So now that we've discussed some of the blood gas testing basics and pre-analytical variables associated with blood gas testing, I want to introduce the project that laboratory and nursing are collaborating on at Phoenix Children's. So this project was initiated after the following case was brought to the laboratory's attention. So a teenager presented to the ED with uncontrolled type 1 diabetes. And based on the clinical presentation, the clinical team suspected the patient was in diabetic ketoacidosis or DKA. In the ED, a VBG was collected with the following results. As you can see, the pH is normal, which is ultimately inconsistent with DKA. The PCO2 is critically low, and the pH is normal, which is also inconsistent with DKA. Bicarb is low, which is consistent with DKA. A CMP was also drawn that included a glucose of 639 mg per deciliter, which is consistent with uncontrolled diabetes. As part of the immediate interventions, the patient was administered normal saline. The clinical team then drew a second blood gas specimen approximately 1 hour later because they were questioning the seemingly normal pH result on the first draw, as it was not consistent with what they thought was the clinical picture of the patient. The second draw results are shown here in the third column. You can see that the pH is below the reference interval, which would be consistent with diabetic ketoacidosis. The PO2 is within the reference interval, and the PCO2 is still low, but increased compared to the first draw. And of course, the bicarbonate is still low. So if the patient was admitted for suspected DKA, and the pH from the first specimen was normal, while the pH from the second specimen was low, which is consistent with specimens low, and which is ultimately consistent with the clinical picture of the patient. What could explain the normal pH result on the first draw? Is it because the normal pH is actually consistent with the clinical picture of the patient and there was a mistake by the clinical team? Or are the results consistent with air contamination in that first specimen? Or could it be that there's a delay between the collection and resulting of the specimen? Or could the specimen have been clotted? Based on the pre-analytical variables that we discussed in the earlier slides, the discrepancy is likely the result of air contamination of that first specimen, as that second specimen that was collected approximately 1 hour later is actually more consistent with the clinical picture of the patient, which was diabetic ketoacidosis. So after this inquiry and the laboratory findings, we started to wonder just how prevalent air contamination was in our blood gas specimens. We ultimately pulled 2 months of blood gas data from this facility specifically, where this case originated, and what we found was that approximately 30% of blood gas specimens had potential air contamination. What this told us was that we have a problem that is seemingly rather prevalent. It was clearly impacting patient results because, again, we were reviewing results or blood gas specimen results that had already posted to the patient's chart. And we were estimating that 30% of these resulted values had air contamination. And then ultimately, because of this, some type of resolution and intervention was required because we cannot continue to result blood gas specimens in this way. So before talking about next steps in this investigation, I want to take a couple of slides to discuss the laboratory and the facility where we discovered this problem, as well as how blood gas specimens are collected and tested at this specific facility. The facility that I'll be referring to for the rest of this presentation is actually a small community hospital that is part of the Phoenix Children's System. The hospital opened in 2024, so it's a new facility, and had just opened when we had this feedback regarding that blood gas specimen case that I just shared on the previous slides. At this facility, we have an ED, a small inpatient floor, as well as some surgical suites and other minor procedure rooms. In this hospital in particular, as well as our healthcare system as a whole, most specimens are collected by nurses and are drawn from lines. And when we're talking about blood gas specimens specifically, most are actually venous specimens, not arterial. And again, that's just due to the invasive nature of arterial sticks. We don't routinely, especially when we're talking about ED settings or patients that aren't in ICUs, we're not usually going to do arterial sticks. So if we look at where blood gas specimens are collected and tested at this facility, you can see that we use a hybrid approach. So all samples collected in the ED are sent to the lab for testing, and they can be sent to the lab either via pneumatic tube or hand carried. So the lab is actually adjacent to the ED at this facility. Of course, in the laboratory, we have laboratory technologists that are performing the testing. On the inpatient floor, all testing is performed at the point of care by respiratory therapists. For samples collected in the OR, testing is performed at the point of care by nurses. Although we have testing at the point of care and in the laboratory, and the testing is performed by multiple different operators, all locations for testing actually have the same model of blood gas analyzer. And I will disclose that it is not a handheld device. So even at the point of care, we do not have a handheld device for blood gas testing currently. I also want to point out that although at this site we do have blood gas testing in the laboratory, historically and at our primary hospital, there's no blood gas testing that is performed in the laboratory. And actually all blood gas testing is overseen by point of care. So I'm hoping I'm illustrating with this slide is that blood gas specimens are collected by many different individuals with different levels of training. They're also tested in multiple different settings by different types of operators. I also hope I'm illustrating that this approach ultimately is lacking centralized oversight. Considering this in combination with the knowledge that this is a new facility, it might not be a surprise that we're seeing specimen integrity issues when it comes to blood gases. So with this in mind, we reviewed the training material for sample collection, the training material for instrument operation, as well as any SOPs we had that were associated with blood gas testing. What we found is shown on these 5 panels on this slide. The first discovery was that the collection training did not include the unique collection requirements for blood gases. Specifically, there was no mention that they can't be exposed to air. Our second finding, also related to collection training, was that it did not include sample handling instructions upon collection, so that if you do introduce air, you have to expel it immediately, and there was no mention of mixing the specimen immediately upon collection. We also found that the point of care procedures did address sample air removal at the time of analysis, but not at the time of collection, which is a problem if there's a delay between specimen collection and actually running the specimen. We also found that personnel trained to run blood gas specimens, whether it was in the lab or at the point of care, were actually not trained to identify sample integrity issues. And then finally, we also found that there were no formal specimen rejection criteria that anyone was trained on or in the procedures. So we ultimately identified, as you can see on this slide, that there were multiple areas that were inadequate, but based on the issue being pre-analytical, that air contamination issue, and the gaps in the specimen collection training and procedures, this is where we really decided to focus our efforts. Not that we were not going to identify the other issues and try to rectify them, but the specimen collection pieces were clearly lacking and offered a lot of opportunity for improvement. And as mentioned previously, most of our specimens are collected by nurses. So to address this issue, it really requires a collaboration between laboratory and nursing, and it requires this multidisciplinary approach. So we ultimately initiated a joint lab nursing quality improvement project that was aimed at providing accurate venous blood gas results by implementing facility-wide blood collection practice changes that would reduce the percentage of blood gas specimens with pre-analytical air contamination. The ultimate goal was to reduce the percentage of VBG specimens, or venous blood gas specimens, with ambient air contamination from a monthly high of approximately 30% in September 2024 to less than or equal 2% by July 1st, 2025. So it's a rather lofty goal, I would say. I also want to quickly mention that we are looking at venous blood gas or VBG specimens specifically, as those are the primary specimens collected at this site where this case was brought to our attention. However, the same principles would apply to all blood gas specimen sources. So the same principles for trying to reduce air contamination would apply no matter what your source is. So in this slide, I will review the process that we use to identify the VBG specimens with potential air contamination. We performed monthly retrospective review of all resulted VBG specimens to identify those with suspected air contamination, and then just did a simple calculation to calculate the percentage of total specimens that were resulted with suspected air contamination. The criteria we use to identify samples with suspected air contamination are shown in this table. I think there's multiple different ways in which this could be approached, and we could use different parameters, but we settled on these parameters in the very beginning as we thought it was very easy to identify. So ultimately we used oxyhemoglobin and SO2 percentages that were greater than 90. Again, because these are venous blood gas results. So oxyhemoglobin and SO2 greater than 90% is not consistent with a venous specimen, as you can see here based on the reference intervals. In addition to identifying the percentage of specimens with air contamination, we also tracked the percentage of blood gas specimens that were rejected due to specimen integrity issues. We did this to ensure that any reductions in the percentage of blood gas specimens with air contamination were actually due to improved collection processes and not just due to improved rejection criteria. Even though it is important to ensure that specimens are rejected when they don't meet acceptance criteria, we wanted to evaluate if our interventions to help improve our specimen collection processes were actually successful. As part of the project, there were both lab and nursing specific interventions. From the lab side, in February, education on blood gas interpretation was provided, and this required all the techs to review slides and actually work through different blood gas interpretation problems. Additionally, at the same time, blood gas specimen rejection criteria were also proceduralized and implemented. The first nursing-led intervention was the hands-on blood gas specimen collection training. In this in-person training, nurse educators emphasized proper blood gas specimen collection practices, as well as expelling of air from specimens when air was introduced into the specimen. It included a direct observation checklist for initial competency evaluations as well. The information regarding reducing air contamination and the hands-on training, as well as during later interventions, are shown on the next two slides. There are two main ways that we can reduce air contamination. The first one is just that we ideally prevent any ambient air exposure during the collection process. This can be done by drawing directly into a blood gas syringe. Do not collect blood gases into evacuated blood collection tubes, and do not drip samples from a line into a specimen container when you're collecting for a blood gas. If for some reason samples are not able to be drawn directly into a blood gas syringe, but instead need to be transferred to a blood gas syringe after being collected in some other type of device, that transfer needs to be completed without exposing the specimen to ambient air. While it's not a best practice at our institution, samples are most exclusively drawn from lines, and so most often they are drawn into a syringe that has no anticoagulant and then distributed into evacuated blood gas or evacuated blood collection tubes, as well as blood gas syringes. And again, we worked with our nursing educators to come up with a process to have a syringe to syringe transfer that did not expose the specimen to air. Again, it's not a best practice. The best practice would be to draw directly into the blood gas syringe. The second way in which to reduce air contamination is just to expel any bubbles or air that was introduced in the sample during collection, and that has to be done immediately after the collection. To do this, you just hold the syringe upright and gently tap to move any air bubbles to the top, and then you push any air out of the syringe and cap the specimen. After the hands-on training in March, completion of online learning modules were also required for all nurse collectors. The online learning modules were mandatory and focused on the why behind why we were implementing these practice changes. So it talked a lot about how having air contamination, how it impacts the results and how it can impact patient care. Like the hands-on training, the learning modules really focused on the proper draw technique and specimen handling. And it also included a quiz to test knowledge. Approximately 1 month later, a specimen collection form was initiated, and this was actually the suggestion of our nurse colleagues. This form asked for the specimen collectors to identify how the sample was collected. For example, was it collected directly into a blood gas syringe? And also to identify how the sample was transported to the testing location. Was it hand carried, or was it sent via pneumatic tube, or was it collected right at the patient bedside and tested right at the patient bedside, Ultimately, even though this was suggested by our nursing colleagues, ultimately the collectors found this form to be too cumbersome, so it was only used for a few weeks. So we really didn't see any positive feedback from this form. In July, so a couple months later, we initiated direct employee feedback. This involved direct contact with those collecting specimens. So after monthly review, if there were specimens identified as having air contamination, direct feedback and conversation was provided to the collector. Additionally, if during monthly data review, specimens with excellent quality were identified, those collectors were also directly contacted and provided feedback on their excellent specimen collection practices. So on this slide, I summarize the impact of the various interventions. So the data here include all the pre and post intervention data. So this is over 1 year of data. On the y-axis, we have percentage of total blood gas specimens, and on the x-axis, we have the associated month. The blue line represents the percentage of VPG samples identified as having air contamination, while the orange line corresponds to the percentage of specimens that were rejected each month. As you can see, there is significant variability between months and the percentage of specimens with air contamination. In the very beginning, after we identified this as a potential initiative during what I call the project socialization time period, we see a decrease in the percentage of specimens with air contamination. However, this decrease was not maintained. As you can see in the intervening months, before any interventions were made, there was variability in the percentage of blood gas specimens that had air contamination. So I'm just going to quickly flip through so you can see when each of the interventions were completed. But ultimately what you can see is that with each intervention, there are variable responses in the percentage of blood gas specimens with air contamination. As you can see, even though the goal was to reduce the percentage of air-contaminated blood gas specimens 2% or less by July 2025, we clearly did not accomplish that goal. But once we saw that we didn't achieve it and we were not going to achieve it, we didn't stop our conversations with nursing. We actually continued them, and that's where the suggestion from one of our nurse leaders to implement the direct employee feedback came from. After implementing the direct employee feedback, we thought we might have a path to success. If you look at July and August, we can see that there was a decrease in the percentage of specimens with suspected air contamination. But as you can see in September 2025, the percentage of air contaminated specimens did increase. So although we didn't achieve our goal, I think we learned a lot of lessons that we can take forward with us. So some of the lessons that we learned are, one, it's really difficult to overcome long-standing collection practices. Although this was a new facility when this project started, many of those responsible for specimen collection also work at other hospital locations within our system. So this suggests that we could have a systemic issue across all of our hospitals, and it also illustrates that it's very difficult to change these long-standing collection practices, especially if we're trying to make a change at just one site and it's not being rolled out at another site. We also learned, which should be pretty obvious, that having appropriate and clear training material and SOPs are needed before anyone collects a blood gas specimen. During this process, not only did we learn that we didn't historically have blood gas specimen training material, we also learned that there were no competency requirements for specimen collection in general for those that collect specimens at our hospital. And even after we implemented these new collection training material that was part of the project, and all these training materials that were specific for blood gas specimen collection, it was not a requirement for new employees to go through this training before they collected a blood gas specimen. So we discovered this during our direct feedback phase of the interventions, where many of the specimens that were collected and had air contamination were actually collected by new employees, and they hadn't received the training. And finally, this isn't a one-time training initiative. If we want to be successful, this has to be a long-term and iterative process, which really requires buy-in and support from upper levels of leadership and management, because without that, we can't really implement and maintain these culture and practice changes. So which brings us to our next steps. So This is going to move forward as an enterprise level task force and it's going to be established this quarter. And the intent is to address blood gas specimen collection processes across the system. We're not going to keep it isolated to just one facility. The task force will have an enterprise project manager to engage stakeholders across various departments and get buy-in. What we ultimately found is that it's a challenge to have just a few people from the lab and a few nurse educators to really be able to get the buy-in needed to make such a large culture and practice change. Additionally, we are going to take steps to centralize oversight of blood gas testing across the system, as having such decentralized oversight likely has allowed for these preanatal problems to persist for much longer. So hopefully next year I can be back and describe how these next steps actually led to a reduction in our blood gas specimens that had air contamination. So finally, I just want to thank and acknowledge my collaborators, Amy Lawrence, who is the co-project leader. She's a lab manager and the point of care manager here at Phoenix Children's. She made significant efforts to gain trust of our nurse colleagues and promoted open dialogue between the educators, the lab, and the nurses that were performing the specimen collections. Diane Bennett, our ACNO, who was really the driving force for this project on the nurse side, and just a huge supporter of these types of quality improvement projects overall. And then I've listed the 3 nurse educators that we worked with very closely. They led all the hands-on training, they created all the training material, and were just overall very passionate collaborators on this project. And with that, I would like to thank you for attending my presentation.